that pituitary is by far the most important as far as the endocrine glands are concerned, because it is regulating the entire system. So when we talk about pituitary physiology, we are pretty much talking about the growth hormone physiology, we are talking about the thyroid physiology, the adrenal physiology, and the AVP physiology. So pituitary, of course, is very important. But what is more important than pituitary is the hypothalamus, because hypothalamus is the ultimate controller of pituitary. Pituitary is basically encased very nicely in the sella turcica. And this is a very important part because it's an important structure. You want to defend it. It also is important because it gives you a route to enter the pituitary through the transsphenoidal region rather than going for the cranial region. And that's an important part to remember in that perspective. So it's within the sella turcica. Above the pituitary is the hypothalamus, which we call as suprasellar region. So this is sella and suprasellar. Then we have this median eminence, and this is important when we said that 5% of AVP neurons, the vasopressin neurons, will terminate in the median eminence, and that will prevent happening of diabetes insipidus. Then very important structure, which is very close to the pituitary, is the optic chiasma. So we'll discuss this when we talk about sellar mass, is that when the pituitary enlarges, it goes more towards in an upward direction. Because here there is bone, so you can't go. So you will go where you have got this diaphragm sella, which is there, and it will hit the optic chiasma. So what are the initial ophthalmological manifestations of a slowly growing pituitary adenoma? Dr. Dhwani.
In the optic chiasma, there is crossover of the
Yeah.
The earliest manifestation will be temporal hemorrhage.
Temporal heminopia, which will be there, and color vision as well. So part of those are also responsible for sharper vision. So color vision will also be affected in that regards. What about headache? When does headache happen in a pituitary lesion?
So headache mainly occurs because of capsule enlargement. There is rapid capsular enlargement regardless of the size or lesion.
So headache is a common thing. You can't say that somebody has too severe headache, his lesion has to be big. Even a small lesion can cause more headache. So headache is not because of raised intracranial tension. This is what you need to understand. It's more of a irritation of the nerves which are there in that perspective. If you have a very rapid progression, a rapid increase in pituitary size, Dr. Vibha, what do you think will happen?
So then the pituitary will expand laterally. It will expand into it will break the lateral side and it will expand into the cavernous sinus, and then it will compress the 3/4 or 4th.
So basically, normally, as I said, if you are slowly growing, you will get room, and then you will have that figure of 8 appearance, the snowman appearance, and growth will strike the chiasma. But if there is a very rapid pituitary hemorrhage, which is a classical example of apoplexy, it will break through all the walls, and it will break through. It's like a flood. So flood is breaking through all the dam walls, and it is hitting the side areas which are very protected. So why is this there? It's not only protecting the pituitary, it is also protecting the cavernous sinus. So 3rd nerve, 4th nerve, 6th nerve. So if you have a child who comes to you with hypopituitarism, with ptosis, with pupil dilatation, then you're thinking of a cavernous sinus involvement. You're thinking of a possibility that there could be a apoplexy. So ophthalmoplegia with severe headache is suggestive of pituitary apoplexy. Ophthalmoplegia with severe headache with hypotension is diagnostic of apoplexy, because that will mean that you have a cortisol deficiency. Immediately start cortisol in that setting. Maybe you can take a sample and everything, but this is a classical thing of there could be a acute adrenal insufficiency, which is central in that perspective. So now we know that there is a hypothalamus, which is mainly a neural aspect, and the pituitary. Of course, there is an anterior pituitary and the posterior pituitary. So anterior pituitary is largely being transported and regulated through a chemical signal, while posterior pituitary has a direct connection which happens with these neurons, and the neurons come into that. What we are also seeing is that the blood supply of the anterior pituitary is distinct from the blood supply of the posterior pituitary, and this is important, and this of course is the stalk. So what you're seeing here is that there is a narrowing of everything which is happening at stalk. So it's like a fruit which is hanging via stalk. You see a fruit, if you cut the stalk, then the fruit will not get, or if the stalk is damaged, there will be no supply, and the fruit or flower or whatever will be damaged. So what is the relevance, Nupur, here, do you think, of this infundibulum being such narrow thing? So if you have a small insult here, do you think it will have an impact? So if you have a small lesion in the pituitary, it may not have any impact because you've got a big pituitary. A small lesion may not do that. But in a narrow point, so as we say that if you want to break a particular chain, you attack at its weakest link. So the weakest link of the hypothalamic pituitary axis is actually this stalk or infundibulum. So disorders which are going to affect the infundibulum will have huge impact in terms of pituitary outcome. So what are the common conditions which affect the infundibulum, Dr. Manoj?
Like germinoma, hypophysitis.
So you will have inflammatory disorders like hypophysitis. So the term hypophysitis is a misnomer. It is actually infundibulohypophysitis because infundibulum is involved. And germinoma, of course, we discussed, can be there. Any of the infiltrative disorders like histiocytosis, sarcoidosis, even tuberculosis, they can also have an effect on the infundibulum. Now, how will you differentiate a pure hypophysitis versus an infundibulohypophysitis? Or let's put it this way. You have a lady who presented with some headache during pregnancy, and post-pregnancy, she had lactation failure. And she is weak, she is lethargic, she has got a LH which is low, FSH which is low, there is a hypopituitarism. Now, how will you know that this patient has a hypophysitis which developed and evolved during the pregnancy versus a Sheehan syndrome which is there? So which clinical pointers will suggest the same? So again, we discussed that if you have a particular endocrinopathy, it will tell you this is more likely to be infundibular involvement. That is, so if your prolactin is high, okay, but she has lactation failure, so that is there. Anything else? If she has DI, that will also be an important thing. So if you have both anterior posterior, it cannot be pituitary. I think this is a message which is coming from that in that perspective. Now, from the hypothalamus, you've got the supraoptic and the paraventricular nuclei from which the neurons come and this neurovascular junction. So it's both will be affected if your infundibulum is transacted. So if you have a transaction of the infundibulum, both will be affected. Which hormone will go up if the infundibulum is transacted? So prolactin will go up, everything else will come down. So that is the key message from that regards. And you have got the hypothalamo-hypophyseal tract, which is the neural structure, and the hypothalamic hypophyseal portal system, which is the blood flow, which is regulating the anterior pituitary in that regard. So in a way, anterior and posterior pituitary are developed separately. They have got a different blood supply. They've got a different control altogether. And that's why you don't have a combined anterior pituitary dysfunction in that regard. So of course, we discussed about optic chiasma being close to that, which can cause a problem in that regards. So the blood supply basically comes from the superior hypophyseal artery and the hypothalamic hypophyseal portal system for the anterior pituitary. You have a distinct blood supply as discussed. So if you have an acute pituitary infarction, the posterior pituitary will be preserved in that regards. And therefore, the other thing that we discussed is that you've got a very, very important area, which is infundibulum, which is your a typical scenario of a chicken neck, or you can just hold the thing and you can hold the entire thing in ransom in that regard. So this is a very, very important thing. Any lesion in the infundibulum will have a vast consequence in that regard. So if you have a pituitary abnormality, either the whole pituitary is going or there's a large hypothalamic lesion, even a small insult in the infundibulum may cause a significant problem in that scenario, and that will be affected. So again, 32-year-old lady with secondary amenorrhea, Dr. Manoj, postpartum hemorrhage, lactation failure, everything is low. LH, FSH, everything is low. Cortisol is low. Prolactin is low. So diagnosis? So this is classically a postpartum necrosis of pituitary. But she does not have any DI. So why?
Reason is preserved.
Yeah, and the blood supply is also different for the posterior pituitary. So in this case, none of the AVP will be affected actually. Even if you had, there's no posterior pituitary involvement at all because there is a distinct supply, which is the differential blood supply will help it out in that regards. If she had DI, and the prolactin was a bit high, I will think of an infundibular hypophysitis, which is a very close differential between the two. So often we will not get these history of hemorrhage which has happened and Sheehan may not present, but gradual onset post-pregnancy hypopit. So secondary amenorrhea after the pregnancy, then these two differential become important. Now, very important to learn about the paracellular structure because this will be relevant when we talk about the cellular mass. So what we're doing today is to slightly build up the base for all the 7-8 lectures we'll talk about pituitary. It will make it much easier then. So we know that this is the anterior pituitary and this is the neurohypophysis, adeno and neurohypophysis. There is a sphenoid bone. This is a different angle. So this is the sella. So you can directly reach from the transsphenoidal route to do it's so easy to access. I think this is one of the good thing which happened for pituitary surgery. You don't have to be an invasive procedure. Just through that you can have it. Now, of course, this is the cerebellum, this is the pons, and that day we discussed in detail about how pons can have a problem in the setting, but usually pons is quite distinct. Then we have got the stalk, so which is like this thing which is taking the fruit, which is lying down. And of course, you have corpus callosum in that regard. Now, if you look at the structure in a more of a coronal section, this is the pituitary within the sella, and this is the chiasma on the upper part of it. There is bone which is surrounding around 90% of this pituitary. So there is a hole which is there, which is sort of a escape mechanism for the tumor to grow. Otherwise, it would have caused significant pressure or other symptoms. So when the tumor grows, it will grow in the upward direction. That is important. Very importantly, this region of stalk is very close to the optic chiasma. So you have got this diaphragm sella, which is a soft tissue structure which the pituitary can push and go upwards and press the optic chiasma. Now, this is the sphenoid sinus, which we saw you go through the transsphenoidal route in that perspective, and very important structures which are there within the cavernous sinus are the third nerve, the fourth nerve, the sixth nerve, as well as the cavernous sinus and the carotid artery. So the body is protecting these important structure via this bony sella, which is protecting that. Now, the effect as discussed, of course, is that if you have a pituitary lesion, which is a slowly progressive pituitary lesion, it has the best way to go upwards. It will go in an upward direction, and therefore it will have a constriction, and then it will form a figure of 8 or looks like a snowman appearance. And it will really strike the optic chiasma first. This will result in a visual field defect, which Dhwani said is more of a superior temporal involvement. You may have color vision abnormalities. So when you're doing a confrontation test, also look at color assessment, also may be of help. And if, of course, it's progressing, you will finally have a complete blindness in that perspective. You may also have headache because of a stretching of the capsule. It has got nothing to do with the size, so it is not correlating with the size of the lesion. Now, as Vibha said, that if you have a sudden rise in the size of the lesion in the form of a hemorrhage, it may break all boundaries and affect the cavernous sinus, resulting in ophthalmoplegia, which will cause third nerve palsy, ptosis, diplopia, facial sensation, and other abnormalities. So eye and blood pressure, these are the two major things to look at in somebody whom you're thinking of apoplexy. Loss of vision and ACTH deficiency. So you give them hydrocortisone. If the vision is impending, you may need to debulk. So you basically reduce, you take off the blood, and therefore that pressure, otherwise it will improve. So if your vision is normal, you can hold on to do an immediate surgical intervention in that regards. Of course, if there is a sphenoid injury, you may have CSF rhinorrhea, which will have implications in that regards. So we have also discussed about this coronal part. If there is an increase, you will have a visual field defect. If it becomes bigger, so sometimes the lesion may be big and it may involve the hypothalamus. So hypothalamic features are sleep disturbances, visual abnormalities, temperature instability, irritability, behavior abnormalities, and all those things may become, and you will of course have a hypothalamic obesity. What is the basis of hypothalamic obesity, Dhwani? What causes hypothalamic obesity? So leptin, it is a form of leptin resistance. So the central processing unit, so leptin basically does what? The POMC, leptin, MC2 receptor, MC4 receptor pathway is basically causing the central processing unit to say, okay, we have had enough, let's have satiety. If there is a problem in the central processing unit, you will, of course, leptin will not work. So it works like a leptin resistance in that regards. So that will be the hypothalamic obesity. Of course, now we have said that cellular lesion will not cause DI, but if you have a very large cellular lesion which is damaging the hypothalamus, the stalk, it may also cause DI in that perspective. If it goes towards the more frontal region, it may cause seizures, and of course frontal lobe features like personality changes, anosmia, those things may happen. So 15-year-old girl with headache, low-grade headache was going on for quite some time. Then there is a sudden increase of headache and she comes to you with shock. So Vibha, what are you thinking of?
Sudden headache with shock.
So pituitary apoplexy. So what will you look at on examination? So your blood pressure, of course, she is in shock. So there is hyponatremia, which is there. Potassium is normal. Why? So it's a ACTH cortisol deficiency. Aldosterone is intact. You've got low cortisol. You've got low thyroxine. What will you look in the eye examination? And pupils, ptosis, there is a squint, all those things. So you will, of course, get this. Of course, the eye is being removed, but there is a ptosis which is there and deviation. So this is a follow-up case of a girl who had these sudden features. There is a permanent third nerve palsy, and now she is multiple pituitary hormone deficiency. So MRI showed an adenoma with bleed. So this you have to be aware of. Now we need to really understand also as to where are these cells located. So the major cells which are there within the pituitary include the growth hormone, the TSH, the ACTH, the prolactin producing cells, and gonadotropins. Now, if I ask you, Nupur, in terms of importance, so suppose you have to give priority to these cells, which are the most important, most valuable cells, and which are less valuable. Nothing is not valuable, but less compared to the other. So body will like to protect which one the most? No, within the anterior pituitary, ACTH, GH, TSH, LHFSH, prolactin, which is the most important? So ACTH is the most important because that's the life-saving one. Then you will say, okay, TSH may be more important. Then you will say, okay, reproductive and growth hormone. And then these are all luxuries. So this is a fundamental requirement and that's a luxury. So when you are building a castle, you will try to safeguard your most important asset. When you play chess, you want to safeguard your queen or a king. King, of course, is the most important and others can structure around. So the way the body has already positioned these cells is also reflective of that. So what you see, of course, AVP is part of the posterior pituitary. That's different. So in adenohypophysis, growth hormone is like the pawns. They are like the paddle. So they are on the higher side. So you said, okay. And they are very much bigger in numbers also. 50% approximately of the entire population is actually somatomammotrophs, which means they can also secrete prolactin as well. So they have a common ancestral origin. So we discussed yesterday that growth hormone and prolactin are similar structure. They've got similar mechanism of action, cytokine receptor, and same cells can also produce the prolactin as well. So a growth hormone producing tumor can also have hyperprolactinemia. What are the various mechanisms in which a growth hormone producing tumor causes hyperprolactinemia?
And one is this.
Yeah, second. So one is that the same cells are producing both growth hormone and prolactin. Second,
Receptors.
no, hyperprolactinemia. So that will be the next level that you are saying. Second is you have a men, multiple endocrine neoplasia in which you have a pleiotropic tumors can happen. Third is that if this tumor is big enough, it is causing a stalk compression, it will cause prolactin. What you are saying is that if you have growth hormone excess at a very high level, it may also act on the prolactin structure receptor causing galactorrhea. That is a different thing altogether. So you need to remember that there is an overlap between growth hormone and prolactin, which is important. Now, prolactin, again, not very, very important. So again, on a periphery. So these are on the periphery part. So they are more prone to damage if you put it in that perspective. So these are also big. So most of the pituitary, anterior pituitary is made up of somatomammotrophes. TSH, again on the lower side, gonadotrophins towards the closer part and ACTH are pretty much the king of the overall chessboard, and everybody is wanting to protect them. Their numbers are also less. They are like 10%, 15%. So body's major role is to prevent them. Now, how is it preventing? If you are at this point, if there is a trauma, the chance of damage will be less. If you are close to that area, your blood flow is also very good. So you will be less likely to have a vascular injury as well. So generally speaking, we say that if you have a trauma, if you have a radiation injury, your ACTH will be less involved. But there is one condition in which ACTH may have an early involvement, in which there is a damage to the pituitary. Which one is this? Dhwani. So generally, body wants to protect ACTH. So as somebody said that if you are in a jungle, which hormone do you need most? You want ACTH, you want TSH, then you will think of gonadotrophins. So once everything is fine, you'll think of growth, reproduction, lactation is the last, of course. So there is one acquired disorder in which you will have a predominant ACTH effect. And we discussed a lot about that condition just now. So radiation causes less effect. Trauma causes less. What is the other acquired thing? Vascular is also less.
Autoimmune.
Autoimmune. So autoimmune hypophysitis in adults, the usual first manifestation is cortisol deficiency. In adolescents, GH deficiency is also common, but ACTH is more prone somehow to the autoimmune cause. Why? Which antibody causes that?
Sir, is it a deficiency?
Which autoimmune antibody can predict the development of ACTH deficiency? It is against the TPIT. And we'll talk about TPIT, which is actually a genetic expression which works on that. So ACTH, you should remember, is more prone to a damage via the autoimmune etiology, which is there. So if you have a trauma or a vascular insult, growth hormone will go first. So it's unlikely that your growth hormone will not go. If you have radiation exposure, if you have ACTH deficiency, your growth hormone is also gone. If you have a vascular insult, growth hormone is also gone because it's so predisposed. So if your king is in threat, your pawns have already lost. So this is something, this is very simple in terms of the chess analogy you can take off. Then prolactin will become involved. Then ACTH is the last one to go in that perspective. That is why in Sheehan, you will see zero prolactin, often in most cases. But cortisol is never zero. There is some production. One is that you have a ACTH independent production of cortisol as well. Plus the ACTH is relatively protected also from that regards.